name is Mary Tershak. I have chosen to do wrong site surgery protocol, meaning the timeout process that the OR implements for every procedure that we have to do in the operating room. We have to do a timeout for patient safety, to ensure that we have all the instrumentation, the correct staff, things like that, and that everyone knows what's going on, what the process is, allergies. I'll kind of get into that a little later. I chose to work with Shelby Azar, who is also a fellow RN in the operating room. She has her bachelor's and she's continuing to get her master's as we speak. So the operating room is a very complex place to work, as most people know, and there are all kinds of new policies, procedures, things like that that we have to endure every day. And it's really, we have to be mindful of patient safety, patient comfort, things like that. And this is a top priority. There have been some instances of wrong site surgeries or things left in patients that should not be in them. But since implementing this, that's gone down pretty significantly. We've had some near misses, but thanks to this, it kind of keeps things in check. So the wrong site surgery protocol is, the purpose of it is to determine what the current state of knowledge is regarding the use of surgical timeouts to prevent wrong site surgeries for operating room nurses. Performing a surgical timeout and having a policy in place to mandate surgical staff to document the timeout will help decrease wrong site surgeries, thus increasing patient safety. The objectives that we decided would be best for this is that staff will verbalize an understanding of the timeout process and the importance of it to help prevent wrong site surgery in the future. Staff will complete a post-test after reading information sheet and poster on the unit and turn it in for evaluation to determine knowledge base. And I will attach a copy of the timeout policy and procedure to the handout that we are making up. It's like a quick reference type things that they can keep, and if they need to refer back to that, if there's any questions or things like that that need to be addressed, they can do that. The plan, as I stated, was to create a poster and put it on the unit for viewing, to make a handout, and to have a post-test to determine their knowledge of the topic. That's kind of the implementation process. We did go over, review the current policy at Carilion, and upon looking through it and things like that, it's pretty on point with what national recommendations are. The current practice in the operating room at Carilion is that the RN will verify patient identity and that the site has been marked prior to going to the operating room. Timeout 1 is done intraoperatively, pre-induction, when the patient enters the operating room. The anesthesia provider, circulator, and scrub tech, or scrub person, meaning it could be an RN as well, will confirm the team members by name, allergies, the patient's allergies, antibiotics, procedure to be performed, the surgical site, the identity of the patient, and the ASA class, which anesthesia actually determines for us. Timeout 2 is done pre-incision. It's a verbal timeout, and it must be done in OR by the entire surgical team. It's to be done after the drapes are in place, immediately prior to the incision. The surgeon will initiate and confirm correct patient, site or side and or side, procedure, the implants if there are any, radiographs meaning x-rays, things like that, antibiotics, what medications are on the field, anticipate a blood loss that is greater than 500 milliliters, surgical staff, and VTE prophylaxis such as SCDs, things like that. The timeout 2 is kind of a point of discussion in the operating room, and one of the other students in this class, actually Robin, will attest to this, that it's done after draping, but a lot of the surgeons are really pushing it to be done after we prep our patient or prep the surgical site, because there's a 3-minute window. It's just straight downtime because you're literally waiting for paint to dry on a patient, basically. So that's actually the most calm time in the room at our facility, whereas with the draping, after you drape, you're passing off your cords, everybody's chomping at the bit to get the surgery started. We need incision time, we need to get things rolling, we need to make this process fast. because that's just how the operating room is. It's a money-making facility. It needs to bring in the revenue, things like that. So they are really kind of pushing for, the surgeons, as in they, are pushing for us to do the timeout during that 3-minute prep time wait. I don't know that that will change. It's a pretty good idea because it is the calmest time in the whole procedure, but we'll see. Hopefully with discussing, and that's maybe something I could include in this, is, you know, questioning when is the best time and maybe revamping that policy to make that an option. Well, not really an option, but make that the policy and procedure. And the third timeout, or as we call it, is a debriefing. It's post-op debriefing. The surgeon confirms what procedure was performed, the post-op diagnosis, the labeling of the specimen if there are any, the status of the counts, verification of wound class, equipment problems, any concerns, and a brief op note must be submitted in the computer. We, as the circulator, the RN in the room, have to document the date, time, and sign all 3 timeouts in the computer. The timeout and surgical safety verification is crucial because, as you know, if you don't document it, it didn't happen with nursing or with anything medical. This policy has more than the requirements that are actually mandated by the Joint Commission, so that it's a good policy and play and things like that. But I think that with any policy and procedure, especially something this critical, you really do need staff to be 100% on board and 100% compliant regardless of what the situation is. Some facts about wrong site surgery are that it is the 4th most common sentinel event after patient suicide, operative and post-operative complications, and medication errors. And the errors are often due to human elements such as emergency cases, unusual patient characteristics, and time pressure for starting or completing a procedure, OR logistics, multiple surgeons conducting surgery during a procedure, and multiple procedures being conducted at once. One of the things that I have noticed in the operating room is we do have a lot of staff that come in and out, which can impact things, but we really try to keep control of that. The summary of evidence is kind of what I just went over. Effective communication is key among healthcare professionals, and it's vital to the delivery of patient safety. This procedure with the timeout and wrong site surgery protocol has been in place since 2004, actually. Instituting a timeout policy and protocol is more cost effective than a wrong site surgery, obviously, because training your staff, getting them knowledgeable in the process and things like that is very important. It takes a minimal amount of time to perform and increases patient safety tremendously. And as I stated, documentation of surgical timeouts is necessary to ensure they are properly completed. It says, I said too much, that best practice regarding performing surgical timeouts for procedures is to follow Joint Commission's protocol and personalize it according to the facility's needs. Ensure all staff are knowledgeable concerning timeout policy and procedures at the facility. And as I stated, document by the RN. It's 100% necessary, and we just have to do it. In conclusion, I think that it is crucial that we do this timeout and that we really get staff on board, that they have these pocket options to refer to and things like that. On the OR doors, we do have the timeout 1, 2, and 3, and also in each surgical pack, we have the stop sign that is this neon yellow that we instituted, and you have to go over this before you can make an incision. So they are going in the right direction. I think what I really want to push with this is the necessity of staff compliance and their understanding, and like I said, I'm going to evaluate that by providing the poster, giving them the documentation here in the brochures and a handout, and actually doing a post test and having them to put that in an envelope to see if they really do know the procedure, how well they know it, if there does need to be more training and things like that, and if there is, then you put an in-service online and they have to be checked off on that. The problem with that is you do the in-service, you read back and review all of this, but it doesn't necessarily mean you understand it completely, and you have to understand this as an RN in the operating room. So that is really all I have to say, and we'll see how it works out. Thanks, guys.